تمام. فين؟ بسم الله الرحمن الرحيم. Our session now is about the new advances in treatment of cardiorenal syndrome. First, we're going to have short notes on cardiorenal syndrome. Cardiorenal syndrome is an acute or chronic dysfunction of the kidney which affect the heart. So the kidney and the heart are interacting organ because the kidney is receiving 25% of the cardiac output, which makes the kidney very susceptible to any change of the heart function. Interaction between the heart and the kidney is known as cardiorenal syndrome, whether the kidney affecting the heart or the heart affecting the kidney, or both are affected by the same disease. Cardiorenal syndrome is classified into 5 types. Type 1 and type 2 are heart disease affecting the kidney. Type 1 is acute heart failure resulting in acute kidney injury. Type 2 is chronic cardiac dysfunction causing chronic renal disease. Type 3 is acute kidney function affecting the heart. Type 4 is chronic CKD causing heart dysfunction, which may be manifested by coronary heart disease, heart failure, or arrhythmia. And type 5 is acute or chronic systemic disease affecting both the heart and the kidney by the same disease. So, is there any coincidence that to find heart and kidney disease together and it's not a cardiorenal syndrome if each organ is affected by a different disease? What's the prevalence of cardiorenal syndrome? Renal impairment is very common in patients with heart disease. No, we're going to focus on type 1 and type 2, which is the renal disease is affected by heart disease. Type 3 and type 4 is usually concerned with the cardiologist, and type 5 concerned both nephrologist and cardiologist. 30 to 60% of patients with heart failure usually have moderate to severe renal impairment. And 20 to 30% of patients with heart disease undergoing treatment usually have recent deterioration of renal function. What's the pathophysiology which causes the heart disease affecting the kidney? The process is multifactorial and it includes neurohormonal adaptation, reduced renal perfusion, increased renal venous pressure, right ventricular dysfunction, reduced systemic blood pressure. Reduced systemic blood pressure is a very important factor in causing renal dysfunction in patients with heart disease. And neurohormonal adaptation, which is an adaptation, but it harms the kidney. This neurohormonal adaptation is mainly due to decreased cardiac output, decreased filling of the blood vessels, in addition to venous congestion and the congestion of the right ventricle. All these will contribute to 3 main factors which occur and harm the kidney. First is activation of renal angiotensin aldosterone system. Second is activation of vasopressin, causing salt and water retention, in addition to other factors. Reduced renal perfusion is a result of both venous congestion and decreased cardiac output. Decrease of blood pressure is a main factor which affects the kidney in patients with heart disease. And this study concluded that blood pressure decrease rather than alteration in the cardiac output or central venous pressure were associated with a change in serum creatinine during treatment. So hypotension is a major factor. How to diagnose patient with cardiorenal syndrome? To diagnose cardiorenal syndrome, patient should have a normal kidney function, similar to hepatorenal syndrome. In type 1 and type 2, the kidney should be normal. So urine analysis should be plain without any sediment, and the kidney size with ultrasound should be normal. And renal function show recent deterioration. If the patient has chronic CKD and develop heart disease, whether type 3 or 4 or separate from each other, this is not a type 1 or type 2 cardiorenal syndrome. Presence of renal impairment in a patient with heart disease has a very bad outcome. and reduced GFR is generally associated with worse prognosis in patients with heart failure. All-cause mortality in a patient with heart disease was significantly higher in the patient with worsening renal function compared to those with a serum creatinine that was unchanged or increased by less than 0.2 ملغ per deciliter. الجملة الأخيرة دي برضو غريبة شوية، يعني إيه or increased by less than point، يعني الرينال فانكشن مسموح لها برينج معين في التحرك whether lower or higher. If it exceeds this limit, it will make the prognosis worse for patients with heart disease. This study was carried out 2006. Shows that after follow-up of 1 year, 38% of patients with any renal impairment and 51% with moderate to severe renal impairment died after 1 year. Patient with heart failure, the death after 1 year was 38% for any patient with any degree of renal impairment, and 51% of patients with heart disease will die after 1 year if they have moderate to severe renal impairment. This is in contrast to 24% in those without renal impairment. So there's much difference in the mortality of a patient with heart failure if he has renal impairment. And mortality worsened incrementally across the range of renal function. The more deterioration of renal function, the more the mortality of patient with heart disease. There is some evidence showed that patient with improving or worsening renal function may have worse outcome. In general, patients which have deterioration of renal function will have a bad prognosis in all-cause mortality. But patients who have improving renal function even will have more mortality, and those who are with a stable renal function during treatment of heart failure will have the best outcome. Our talk today, we're going to concentrate on the management of patients with CRS, especially type 1 and type 2, which is a renal disease which is affected by the heart disease. This is very similar to hepatorenal syndrome. Improvement of the cardiac function. First management of CRS, type 1 and type 2 is improvement of cardiac function. Improvement of cardiac function will improve much renal function. However, in one study carried out on 4,917 patients with continuous flow left ventricular assisted device enrolled in the INTERMAC registry demonstrated North America, demonstrated improvement in serum creatinine and reduction of blood urea nitrogen among patients with baseline moderate to severe renal function. So left ventricular assisted device will improve the renal function. However, in some studies in this registry found that this improvement of renal function is not long lasting. Within 1 year, both will be similar. So improvement of cardiac function will improve renal function within a limit. Diuretic. Diuretic is the main stay of management for patients with heart failure, and typically, usually we start with loop diuretic as a first-line therapy to manage volume overload in a patient with heart failure. With the start of diuretic, serum creatinine may rise, decrease, or remain unchanged. Serum creatinine will rise with the start of diuretic due to reduction of renal blood flow. Remain unchanged if the condition of cardiac output was as a flat part of the curve of Starling law. But the renal function may decrease due to reduction of the venous intra-abdominal pressure and the venous pressure, which will improve the renal blood flow. The best outcome may occur with aggressive fluid removal. So our target is aggressive fluid removal, even associated with mild to moderate worsening of the renal function. So diuretic, we're going to concentrate on removal of the congestion rather than keeping kidney function within the normal range. Even diuretic intake or diuretic administration will cause deterioration of the renal function. To what level we are going to tolerate deterioration of renal function with diuretic? Some studies showed that reduction of GFR up to 15% will have a reduction in overall mortality. And other studies reached up to 40% reduction of GFR with 40% with the diuretic can improve the outcome of the patient. So we're going to tolerate deterioration of renal function on GFR with the diuretic because the total outcome of the patient will be better. Second line of management or third line of management of heart failure is the renal angiotensin system antagonist. ARBs or ACI is the standard part of treatment of patients with heart failure with reduced ejection fraction. It's associated with much improvement of the patient outcome as regard cardiac output, but is not generally associated with an improvement of the renal function. Usually start of ARBs or ACE inhibitor associated with deterioration of renal function. It's better to be avoided in patients with CKD to avoid complication like hyperkalemia. But even with ACE inhibitor, although it causes deterioration of renal function and reduction of GFR, the outcome will be much better than without giving it. So we're going to tolerate deterioration of renal function due to diuretics or ACE inhibitor or ARBs. Even it causes deterioration of renal function, we're going to tolerate it because it's associated with low mortality. Next group of drugs, which are angiotensin receptor neprilysin inhibitor. This group of drugs is a combination of angiotensin receptor and neprilysin. This group of drugs decrease eGFR, so it decreases renal function with follow-up, but reduction with this group is less than the reduction caused by ACE inhibitor or ARBs. And even it caused increase in the urine album creatinine ratio in the urine, but it has similar adverse effect compared to ARBs. This study was carried out in 2018, shows the effect, the difference between angiotensin neprilysin inhibitor compared to ACE inhibitor or ARBs as regard patient with cardiorenal syndrome. There is less reduction of eGFR with this group than ACE inhibitor or ARBs. Enalapril was used as ACE inhibitor against sacubitril valsartan group. There is much less reduction in the eGFR compared to ACE inhibitor, although there is increase in album creatinine ratio. So this group is preferred than ACE inhibitor or ARBs alone. What is the difference between this group? If we are going to combine ACE inhibitor with neprilysin inhibitor group, this group would induce the production of BNP, which is brain natriuretic peptide, and this has a much better effect on vasodilation of the blood vessels and sodium excretion by the kidney. So in this study, comparing enalapril, sacubitril, valsartan groups lead to slower rate of decline in GFR and improvement of cardiovascular outcome, even in patients with chronic kidney disease, despite it caused modest increase in urine album creatinine ratio. So this is a third group which you can tolerate deterioration of renal function because it will improve the general outcome. Use of the vasodilator usually used in patients with decompensated heart failure, but all vasodilators are associated with the decline in the renal function, especially if accompanied with diuretic. And this study, which was carried out in 2007, it shows the rate of worsening of renal function was significantly higher with intravenous diuretic when given with vasodilator like nitroglycerin compared with intravenous diuretic alone. So combination of vasodilator with diuretic will cause more deterioration of renal function. So vasodilator will generally have deterioration of renal function even if it causes cardiac improvement. Inotropic drug, dobutamine, dopamine, amylinone, has a role in the treatment of cardiogenic shock in some patients with acute decompensated heart failure. It has been associated with an increased mortality. So the role in CRS is uncertain. The ROSE trial, which was renal optimization strategy evaluation, tested the hypothesis whether low dose, all of us know the effect of low dose dopamine as a diuretic. And it improves urine output and renal function comparing to placebo among a patient hospitalized with heart failure and concomitant renal disease. Low dose dopamine in this study, low dose dopamine didn't enhance decongestion or improve renal function when added to diuretic therapy, even it increased urine output. And this is a study, Rose trial. This is a conclusion in a participant with acute heart failure and renal dysfunction. Neither low dose dopamine nor low dose desirtide enhance decongestion or improve renal function when added to diuretic therapy. So this is a failed group in correction of renal condition. Ultrafiltration. Ultrafiltration is the removal of isotonic fluid from venous compartment via filtration of plasma across semi-permeable membrane. It's considered in patients with acute decompensated heart failure and diuretic resistance and or impairment of renal function. Usually you have restriction of using diuretic if the patient has impairment of renal function or impairment of urine output. So ultrafiltration is a solution. In spite of this, the 3 randomized trial, Unload, Rapid, and CARES, compared ultrafiltration with diuretic therapy, and it was not, there is no advantage of ultrafiltration. Ultrafiltration was associated with significantly greater rate of fluid loss than diuretic therapy, but there is no improvement of serum creatinine. In CARES study, ultrafiltration was compared with a step pharmacological diuretic, including start with bolus diuretic, high dose continuous infusion, and loop diuretic, in addition to thiazide, and then in addition to metolazone, and selected intravenous inotropes. This is a step approach. In patients with worsening renal function and persistent congestion, and CARES show deterioration, ultrafiltration has more detrimental effect on renal function. There are 2 investigational therapies for patients with CRS. Antagonists with vasopressin receptor, which mediate antidiuretic response. All of us know that there is overproduction of vasopressin overaction as a neurohormonal adaptation for congestion of the blood vessels, and also antagonists of adenosine A1 receptor. Tolvaptan is a selective vasopressin 2 receptor antagonist which produce water diuresis, not a salt diuresis. Up till now, tolvaptan is approved only for treatment of hyponatremia in patients with heart failure. So it's not approved for treatment of heart failure, only hyponatremia. And Everest study, there was statistically significant, but not clinically significant, greater increase in serum creatinine with tolvaptan group. So if the patient takes tolvaptan, is going to have deterioration of renal function. And administration was not associated with greater early improvement in dyspnea compared to placebo. Tolvaptan administration didn't result in a higher early response rate, and it didn't improve congestion, and it didn't improve the renal function. Adenosine A1 receptor antagonist, adenosine acting on adenosine 1 receptor, which constricts the afferent glomerular arterioles. This results in the reduction in GFR and increased tubular sodium reabsorption. So theoretically, if we are going to block adenosine 1 receptor, it should have improvement as regards GFR and improvement in diuresis. Selective adenosine 1 receptor antagonism can increase GFR and promote diuresis, potentially acting synergistically with loop diuretic. And PROTECT trial carried out over 2,033 patients hospitalized with heart failure and impaired renal function, was randomly assigned to experimental selective A1 adenosine antagonist, rolufelin, or to placebo. We are going to compare both groups. During the study period, there was no difference between group in cardiovascular outcome or in the rate of persistent worsening of renal function. So this group didn't improve the renal function and didn't improve the congestion. There is ongoing trial which concentrate on diuretic therapy. This trial is still ongoing now to adjust the use of diuretic in patients with heart failure. Some trials are ongoing now as regard objective measurement of volume status to control the degree of fluid loss. And some studies about salt restriction and some studies are evaluating the efficacy of subcutaneous versus oral administration of fursamides. And some studies are now examining the role of urine sodium concentration profiling to assess the adequacy of diuretic response and to guide therapeutic decision. الاستادي الاخيره دي شغاله كويس، هم بيدي diuretic وبيشيك early اليورين صوديوم. If there is no improvement of urine sodium, usually he shifted to another way of diuretic therapy, whether it start increasing the dose, combining the dose, but checking urine sodium is an important to guide the treatment with diuretic therapy. Thank you.